Hello and welcome, Lydia.
Thank you.
So, yeah, Lydia is a friend of ours, and she has kindly also sent in a very little notice, so we are incredibly grateful to Lydia. Lydia is quite a good name. She has had a long career over the past 20 years, which has transcended working as a frontline rehab therapist, a social justice activist, a full-time politician as deputy executive mayor, a public policy maker, a rural development practitioner, and lately disability empowerment consultancy and life coaching. Career highlights have included the supporting the establishment of the disability program presidency, as well as participatory drafting of the National Disability Rights Charter in 1992, the White Paper on Integrated National Disability Strategy in 1997, the Promotion of Equality and Prevention of Unfair Discrimination Act in 1998-99, and the White Paper on the Rights of Persons with Disabilities in 2015-16. She was instrumental in drafting South Africa's baseline country report on the rights of persons with disabilities to the United Nations and has participated in several international conferences on the rights.
Okay, thank you so much. Can I check whether the screen is visible and whether you can hear me clearly?
Yes. Yes, it is again.
Okay, thanks so much. And thanks, Emil. I know it's Saturday and I know for some of it's still early. So I'm not going to try and keep it light, but on a fairly serious subject. And as you've heard, I've been around the block a few times. And I think what's been interesting for me is having worked at front face in rural areas and on the front line and blaming those up there that take the decisions and we just have to sit with it. And then being up there where decisions are taken and blaming those on the front line for not working hard enough. And somewhere we're missing each other. And I really want to speak to those who are here today and say that I think if we stop blaming others and we start saying, how can we work smarter? And how do we really reignite ethics in our practice from a conscience perspective? Whether to some extent we can shift the narrative. And I really want to talk from the conscience perspective, from a heart, mind, and hands perspective. And you will see as I speak about it, what I mean with it. And my focus really is from an ethics perspective, how do we bring those who are last in the queue or not even in the queue to the front? One of the speakers just now mentioned and said, those that do not have services are likely never to get services if we just plan on an incremental basis every year. And I would at this stage like to bring in my mentor, the person that really shaped my practice and my social justice ethos from a very young age as I moved into the rural areas. And I really hope that most of us are familiar with the work of Paulo Freire. Paulo Freire says, to affirm that men and women are persons and our persons should be free, and yet to do nothing tangible to make this affirmation a reality is a farce. And I think if we really look at these words, they are so powerful. And I'd like to call the people who's in the Zoom room and who's physically sitting there reviewcrats, because I think it's the one thing that really ignited me working in the rural frontline for a few years, that the people there are really committed people, that we're not bureaucrats, we're not just doctors and therapists and nurses, but that we are really reviewcrats, in that we are constantly trying to reinvent the system to work better for the poor. So I know that I'm speaking to a fairly passionate group of public servants and practitioners, if we look at what we can find in one room. So I'm really hopeful that this philosophy and words of Paulo Freire resonates with most of us. But my question this morning really is, do we truly walk our talk? Do we do it every day? Do we do it at every opportunity for everyone, and in particular for those left furthest behind? My contention is that amongst our scram for resources and our frustrations and COVID having put onto it what it has, we most probably not. We most probably don't spend enough time with our conscience instead of just trying to kill fires as we go. And if we want to work smarter, we've got to dig back into our conscience. And this picture really, I think, sums it up. We tend to accuse one another. We tend to blame one another. And very seldom do we come together in solidarity and say, instead of being angry at each other, instead of blaming, how do we work together? And it comes from our position of struggle, I think. And it's really around a who me, not me kind of battleground that we find ourselves in. And I think it really is about our struggle to survive our daily battles with the paucity of staff and resources that we often lose our ability to show solidarity, to put those last in the line first. And we tend to show solidarity to those that we believe is last in the line within our sphere of influence, rather than looking at the bigger picture. And I think part of what really speaks to me here is that maybe, just maybe, I'm part of the problem, and that it's important that we begin there when we look at conscience. After all, we all serve the same person. The patient cannot be divided. Sorry, there seems to be disturbance.
Larosha, can you mute yourself, please? Thanks.
Thank you. We after all serve the same person or client. And I think what we tend to do is we tend to take this human being and divide them into pieces that speaks to our professions, without really looking at the individual as a whole. And what often then happens is our focus becomes, and I say this with a shudder, but our focus becomes to make people comfortable in their misery. And I'm going to give some examples, and I know these are strong words, but that really is what people on the ground tell us, what the experience is of health services. And I think if we want different results, we need to do something differently. We need to change our attitude and or our approach and or our belief system in possibility. And I think, and I'm going to repeat this, our belief system in possibility. Too often we've given up and we just continue to put one foot in front of each other. And we actually do not believe in our system of possibility. And then we need to aspire for more, and we need to expect better. And we need to wake up every morning aspiring for more and expecting better from ourselves and from the system in which we work. We need to really look at how we put those last first. And I think part of the problem sometimes is, how do we identify who is last? Because equitable access to healthcare ultimately requires conscious, measurable, political and administrative choices. And I can add professional choices in here, decisions and actions. And I think if we accept this, we can stop talking of, yes, but they took our posts away. Yes, but they reduced our budget. Yes, but they reallocated, without identifying who are the they. And if we cannot identify who are the they, we must own it as us. If we can identify who are the they, we need to name them. They need to take responsibility for the impact of decisions. Too many people get away with they. Ultimately, it's human beings making up a system. So to blame the system without blaming the individuals in the system really becomes a futile exercise. And I really think we need to apply our conscience to our choices, to our decisions, and to our actions. Sorry. I think we are all aware, and as guaranteed in the Bill of Rights, the equality of outcome demands that redress features prominently in the options, decisions, and actions we take. How often do we in 2021 still look at issues of redress? That was the key word post 1994. 27 years later, how many of us still think there's a need for redress, think that we've reached the ultimate, or have simply given up? And that is also the decisions we take as health professionals. Now, I'm sure all of us are more than aware, aware of and know the little graphics around equality and equity. And for those that aren't, and for those that maybe can't see the screen, equality very simply takes the available resources and it allocates it equally. So there are 3 soapboxes. People are trying to watch a game over a fence, and each one gets a soapbox. But we can see the actual outcome of that is not equality, because the one can see better, the one can see, and the other one can still see nothing, because they are of different heights. With equity, we take the same 3 soapboxes, not more resources, existing resources, allocate them differently, we have a different outcome. Everybody can see the game. So from an equity perspective, we are there. How often in the health system do we really look at equity allocation vis-a-vis equality allocation? How often do we really differentiate, looking at a person as a whole and not just as faceless numbers in the system? Our constitution does not promise equality. It promises equality of outcome, which is closer to equity. And I think it's really important that we remind ourselves, and that we remind ourselves in the spaces of influence we are, that we need to look at also allocation for equity. But there's another graphic that was added as this graphic session, as selection grew, and that is one of liberation. Because sometimes we need to think outside of the box when dealing with scarce resources. And this is really what disability taught me. And instead of fighting over the existing resources, which is typically what we do, we need to see whether there's not a different way of dismantling the sources of inequality so that we have more resources to play with. So in the instance of the MEMI, they simply removed the wooden fence that obscured the view. So they did not need 3 soapboxes. Those resources could be spent elsewhere in terms of service provisioning. And from a disability perspective, from a perspective of a sector of society who doesn't even make it to the queue to get the soapboxes, this is really where our struggle is in the disability sector. But there's a 4th MEMI. There's, I think 5 and 6 is out already. Sorry, I think I've missed a. So the poor health outcomes for most persons with disabilities living in rural areas is an indictment on every leader, on every manager, every professional working in the health system who has failed to use their agency to make a difference. And I know this is really, really hard to understand and to accept, but I'm going to give you 2 examples. Actually going to just go back, sorry. We had a few thousand cases in South Africa of people who went on to TB treatment and came out of that treatment deaf. So they were deafened in their middle age. The health system treated the TB, but in the process they became deaf. And in very, very few instances did the health system, private or public, compensate them for the deafness by either giving them cochlear implants as well as sign language. So we've taken an active individual, economically active, We've deafened them treating their medical condition, but did not think it's important for their reintegration into the economy and into their family lives and into their community, to give them what they require that's still available in the health system, which is either a cochlear implant and or sign language. And actually you need both, because we didn't resource those aspects. And I think ethically we cannot defend that. Another example, we would treat a person who becomes disabled as a result of trauma or stroke, becomes paralyzed. Yet there are over 10,000 people in this country waiting for a wheelchair. Some people have waited for as long as 6 years, lying at home in a bed in their excrement, because the health system that can give them their medication monthly, the health system that could fix the initial trauma, save their life through that, was unable to provide decent rehab or simple thing like a wheelchair. If we look at the cost of 10,000 wheelchairs on the entire health budget in the country, it's absolutely minuscule. I always say to the politicians, it is often the cost of 3 or 4 functions that where you're host to launch something. Take that cost and please actually give people some dignity, give them some possibility in their lives by resourcing those that are not even in the queue. And this is what I really mean with we need to focus on ethics in allocating resources. And we need to speak up. I've identified, I didn't say the system doesn't avail resources. I've said where some of the resources could be lying in terms of that. And I know people always say, who, me? And I'm like, yes, you. Because in every case, being a health professional, being a rehab professional, places you in a position of agency. You might feel powerless within that system, but you'd be amazed how much power is really vested in you if you compare that with a client. And it's our responsibility to speak up and to speak out. So unless we are able, through deep reflection and introspection, to confirm that I have at all times used all my agency to place those who are last first, I need to own some of the problem. And I really want to mention here that disability doesn't only affect the individual, it affects its whole ecosystem. It affects the family, but it also affects those health professionals that are seen to be the disability people. And that's the word that a lot of people use. So your therapists, your orthotists, your prosthetists often become the extension of our disability marginalization in the system. And I've heard it just now in the discussion beforehand. How many of us who are not therapists have spoken up when COVID took most of the funded posts that were there for therapists? When I practiced 30 years ago, our problem was that we had posts, but we did not have staff. Today, we have staff, but we do not have posts. How many of us have spoken up against the fact that we have taken away from people a service that could have given them possibility, that could have given them hope, and we have tried to just make them comfortable in their misery? So the next thing I just in ethics want to briefly look at in terms of how our conscience speaks to this is how do the social and professional hierarchies within the health system inform current health services, planning and budgeting? And this is a very unpopular slide with some and a very popular slide with others. Because in 2021, race matters. Certain people have more privilege and are better listened to when they speak up. Gender matters. Certain genders are listened to, more likely to be listened to, are more likely to get their point easier into the budget or into a planning system. Age matters. Qualification, profession matters. There are hierarchies. But I think what really for me started making sense is when I looked at the intersectionalities between that. Because in the intersectionalities often lies the marginalization. If you, for example, would have a young Black therapist who is a woman, she is young, she's Black, she's a woman. If she sits in a room full of older white male doctors or senior administrators, her voice is less likely to be heard. She would have to become almost nasty to be heard. And that is part of where our problem lies. We need to acknowledge that we still have challenges in terms of agency when it comes to who is speaking out. But ultimately, central to this is the person with a disability that ends up without services. And just on a lighter note, for those who wonder why this guy is tied with ropes to his wheelchairs, that's specifically and especially for those of you that speak of the wheelchair bound. This is wheelchair bound. Person sitting in a wheelchair is not wheelchair bound unless he's tied with ropes like this. So next time you speak of wheelchair bound, please provide the ropes to the person you're speaking to. Briefly, what is the impact, or what impact do these hierarchies then have on the health status of disenfranchised healthcare service clients? The efficacy of our investments made, and the morale of health professionals finding themselves on the periphery of health systems management. And I think really what we're talking about here is how do we use solidarity to overcome it, this marginalization that we have within the health system in taking those that are lost in the queue and bringing them forward. My call here today really is for more solidarity within the system. I think we all believe we are marginalized. I think we all think we are on the peripheries of the health system because we work in the rural environments. And yes, that is true. But within that periphery, there are even more peripheries and more marginalized communities. And it's really for us to speak out on that. How can we then improve the health service delivery by moving those last in the queue to the front of more inclusive and responsive health ecosystems? And I've seen quite a bit in the last conversation that fits in with this around, do we broaden the availability of mid-level workers, community-based level workers, contracting workers? And I'm saying to us again, to what extent do we need to simplify what we do and not complicate what we do more? Will it make a difference if we begin the planning and budgeting cycle, for example, by placing documented under or non-provisioning of essential services to, for example, persons with disabilities and their families up front? If we start our budgeting process by saying how many people did not get the basics of what they needed in the last financial year, and let's put them on a first and ring-fence that budget and make sure that we actually provide what needs to be provided. Those statistics are available. But data being available, but not being seen, not being regarded as important, is data not being available. And I'm always shocked at when we start prodding through parliamentary questions, through periodic country reports for conventions, and we ask for data, the amazing amount of data that is forthcoming, that embarrasses the country, that embarrasses us as health professionals, but is never used in the planning processes because the people that's advocating for it do not really have a seat at the table when those discussions take place. And again, I'm saying, let us not say they, let us identify who takes the decisions, who said no, so that we are able to try and bring people around and bring them on onto the difficult discussions. It's difficult questions, it's difficult situations. We sometimes have to compromise ourselves. But I maintain we are passionate reviewcrats and we can do it. And I'm asking myself whether if we raise our individual as well as collective levels of conscience and consciousness, combined with the compassion and courage that we all have, that perhaps can we make a difference? We're not short on compassion and courage, but I think sometimes we are so burnt out, we are so tired of struggle, that our levels of conscience and consciousness can do with a bit of an injection. And I think if we all retrospect and say, within my space, what can I do more for the collective, for the holistic interest of my client? How can I make a difference? I remain shocked if I look at how little progress we've made in 30 years in dealing with, for example, stroke patients, that they get discharged so soon after they've been medically stabilized, sent home with no rehab, no assistive devices, no information, and they must just make do. I ask myself, why did we save them in the first place? Because making people comfortable in their misery is not really what our constitution and what our conscience set out to do. And I think, coming to a conclusion, my call to all of us is that we wake the leader in us. We are all managers, but let's wake the leader in us. Let us aspire for more and expect better. Every morning when we get up, let's make a commitment to that. At every bed of every patient we see, let us make that commitment. Instead of relying on hierarchies and control, let us focus on inspiring trust. It takes strategy, it takes tactics, it takes action. Instead of having a short-range view, also consider the long-range perspective. It links up with how do we believe and invest in possibility, that we imitate less and we originate more, that we challenge the status quo more, and that not only should we do things right, but we should also do more of the right thing. And the right thing is looking at our clients as holistic human beings living in an ecosystem. To come back to my slide, me, not me. You, no, not you. And I really say, how can we make a difference in moving the last in the queue, or those even not in the queue, to the front, by instead of that, really bringing ourselves together in solidarity and let our agency speak for the voiceless. I thank you. I think I've managed to make up some time, so you might have a little bit of a longer tea. But I'm here if there are any questions. And I just note that I don't have sound. I'm not sure if anybody else has sound on the Zoom link.
I think sound from the venue is still not on.
We've got sound now.
Should hear you speaking. Can you speak through the microphone, please?
Can you hear me? That sounded like it.
Russell, we can hear a very distant and distorted version of the venue.
You have to hear it come through the speaker, then you know you're right.
I can hear Madeleine very clearly.
Oh, you can hear me. It looks like it's this.
No.
Can you hear us from this? Sorry, I'm sitting at the laptop, so can you hear me? This is Madeleine.
Loud and clear, Madeleine.
Okay, so Marika, do you want to come and sit here?
Let me change it to the next one. Let me just check.
I think let's just do it through this computer and then we can sort it out in the break.
Yeah.
Okay. So yeah, Marika, come and speak here.
Could the camera perhaps be moved to see Marika and the chair?
Hi. Lydia, can you hear me speaking when I'm at the computer now?
Yes, I can hear you loud and clear.
Thank you so much for a truly thought-provoking, challenging, and truly inspiring speech. I wish we could broadcast this to every single hospital and make professional associations also listen to it. Yeah, from my side, just a massive thank you for really raising the issues that we all need to be focusing on. I think this is almost a follow-on from the wrap-up of the last session of that we need to speak with one voice and we need to put the people first and make the system work for the person and not the person fit the system. So I would like to open it up to the floor. Would anybody like to speak? You're going to have to come to the laptop.
Yeah, thank you very much. It's Victor Fredland here. One of my battles has always been to see who it is we're serving. And I think you highlighted that very well. In equity, doctors, I'm a doctor, and often as a doctor, you think your responsibility is just to the patient in front of you. So if someone takes away your resource to do everything for that patient, then you think they're wicked. And you think that is what involves fighting for the patient. But you don't see all the other patients you're not treating. So as long as you're not treating them, they're not your concern. Because you're a clinician just for that individual, instead of a clinician for a community that you're actually trying to bring equity to. And I think we do need to keep it constantly in our mind to do the best for the individual in front of us, but also realize that we are serving a whole group of people and we have to meet all of their needs and not exclude them because we're busy with case number one. And I think you put that very well in, do we move the person who doesn't even get into the queue to the front of the queue to get their needs met? So yeah, we want to hog all the resources for our clinic, our facility, our subspecialty, our particular hospital. I was a hospital a manager and various other roles. And when the district had a need, I didn't say to myself, well, that's not in my catchment area. I think we have to have a much bigger view. It's in our country, it's within our purvey. If we have sight of it, even if it's in Ethiopia and you're in South Africa, there is a sense of responsibility. Thank you.
Thank you. I love the hashtag clinicians for communities. Beautiful hashtag.
Okay, would anyone else like to say anything? I think you've shaken everybody into a bit of reflective reflective pose, Lydia. I'd also like to say it's a pity that more political heads didn't roll whilst you were up there.
Yeah, well, at least some did, hey?
Yeah, thank you so much for taking the time to come and chat to us. Lydia has also just got back from Kenya. So this really has been a privilege. Thank you.
Thank you so much and good luck to everybody. And keep up being reviewgrats.
Thank you.